Good afternoon. Thank you so much for being with us today. We have a lot of information to cover. We are so fortunate at UVM Continuing and Distance Education to work with Dr. Jan Carney in the Robert Larner College of Medicine's Master of Public Health program. So Dr. Carney has a lot of information for us to digest and to today related to the coronavirus. In addition, how can we think about holidays and upcoming flu season? What really is things that we could be doing to make sure that we are maintaining our health and our safety? So really looking for a lot of advice and suggestions and insight today. Christine Finley with us from the Department of Health. And so really going to give us a glimpse as to what's happening with the Department of Health and what else we should be aware of and thinking about as not only that we head into the holidays, but here comes flu season as well. So I know we have a lot to cover. Thank you, everybody. A few logistics. Thank you, everyone who's joining us on YouTube today. We'll be monitoring those questions in the chat box on YouTube. So please do put questions in. Dr. Carney and Christine are going to give us a lot of information today. If you have questions throughout the presentation, put them in the chat box. We'll grab those and bring them over to share with our presenters. We are recording this presentation today. We'll share out with folks who have RSVP'd. If you're not sure if you RSVP'd and would like the recording, please drop us a note in the chat box and we'll send you the email to make sure we're doing that. My name is Nicole Willie-Fenton. I'm the Content Marketing Manager in the Continuing and Distance Education Department at the University of Vermont. We're going to go over introductions today. We're going to talk about the current trends of what's happening. Flu season is fast approaching. Vaccine approval, what and when? What is that process? Preventing COVID-19 spread, mask science. Dr. Carney has some really interesting studies to, again, prove why it's so important that we're continuing to wear a mask. And here comes the holidays as well. How do we think about gathering with family and friends if we indeed do gather this year? In an overview, we also want to touch on UVM's Master of Public Health program in the College of Medicine, which Dr. Carney oversees that program. Plenty of time for questions, and it wouldn't be a UVM Continuing Distance Education presentation without a ton of resources at the end of our presentation. So let's get in it. As I mentioned at the beginning, we have Dr. Carney with us. She is a professor of medicine. She is Associate Dean for Public Health and Health Policy in the Robert Larner College of Medicine. Dr. Carney, thank you so much for being with us. We had Christine Finley. Where did you just go? There. Oh, I see you. There she is. Christine Finley is with us. She is also in the Department of Health, Vermont Department of Health Immunization Program Manager. Thank you both for taking the time today. Dr. Carney and Christine, I know you're going to alternate portions of this presentation, so I'm going to toss it over to you. Dr. Carney, you want to get us started?
Yes, please. Next slide, please. All right, first, just to orient ourselves, our global cases, and unfortunately you can see the United States with a lot of red. We know that we have more than 37 million global cases and more than 1 million global deaths. And this is from the Johns Hopkins Coronavirus Resource Center, a great resource that you can look at some of the national and global trends. Next. This gives you a sense of trends over time since the pandemic began. And if you look at, as an example, the top green line that is peaked and going down, that's India. And the orange line that had peaked in August and went down looks like it's going up again is the United States. And more the peach color there is Brazil. But you can get a sense of how things are going in pretty much all the countries for which we can get data. Next, please. This is, a lot of people have been talking about this, and I'm not sure anyone really knows, but people talk about a second wave. How's this going to play out in 2021 and even beyond? And you can see in the bottom, this is an article from Nature, that if you look at some of the projections for 2021, some of them are like an annual pandemic and peaks recurrent each year. Some are if immunity lasts longer. As we learn more about the immunity to COVID-19, it might stretch out much longer in between cases. If we get some immunity from other coronaviruses, we might have a different pattern. But it's very interesting to look at some of the leading scientists are trying to project what might possibly happen next so we can be best prepared. Next. this is, as we know now, we're hearing a lot about the United Kingdom and in Europe, and this is in France about some second wave gathers. And we'll show you the next on a little bit about the United States. And this is from the CDC. And again, this is updated regularly. And you can look at the total cases since the pandemic began or in the last 7 days. And you can see how many total cases we have here. Unfortunately, we've had more than 200,000 deaths to date. And the darker red states have had more cases in the last 7 days. And you can see in Vermont, and we'll talk a little bit about Vermont, but there's clearly differences among what states are experiencing and actually what they're doing. Next. So this shows you again from Johns Hopkins. It's a little bit busy, but in the upper left you can look at Ohio, and on you can see from March 2020 to the current time, and then on October 11th they had more than 1,500 cases in a single day. If you look at the top right, you can see North Carolina. It had a peak in July and then dipped down and is back up to more than 2,000 cases in October. And on the lower left, you can look at South Dakota. And you can see this is still increasing more than 700 cases on October 10th. States are seeing different patterns, and part of that we had quite a lot of activity and continue in the South. But we're also seeing this in different areas such as North and South Dakota. And then on the far right, you can see Vermont, where we had a peak in April. And then you can see over September and October. And the scale on the left is much, much different, a smaller number. We've done extraordinarily well, but that doesn't mean that we can relax, really, at this point in time. Next. I wanted to also mention that nationwide, some of the things that have been really unfortunate are that Black people are dying at more than twice the rate of white people. And this COVID racial data tracker is a partnership, and an academic partnership is an excellent source of data. And you can look at this across the country. And these are the kinds of things people and the data people are using to try and make things better. Next. I'll turn this over to Chris to talk a little bit about the extraordinarily timely and extensive data the Department of Health makes available to all of us.
Good afternoon, and thank you very much. So the weekly summary that we'll be looking at right now, I just want to say, goes through October 7th. So you may have heard some things in the news that might seem a little bit different, and we can address any questions later. So the next slide. As we get better at collecting data and we are able to share it more, we get some very busy slides. So I'd like to just take you through this for just a moment and address part of what Jan talked about. The blue line that you're seeing that starts high on the left-hand side and goes low, that's the percent of positive tests that we've had. And they are very important in indicating how prevalent, how much are we seeing that disease in the population. And in the beginning, not everyone was getting tests, if you remember, and only those that were really identified potentially to be at risk were getting those tests. So we had a much higher rate. But now we're doing a lot of tests, 30,000 tests in the week that they reported, 30,236 to be exact. And so we're seeing a much lower test positivity rate. When we look, Vermont's percent of positivity, either among tests or among people, has remained the lowest, one of the lowest states in the entire country since May. So we've been doing really well on that. And I just want to, if you look at the pie graph in the right-hand side, that the percent positive to date is 1%. And when New York City had the massive outbreak and problem in late March and April, their rate was up to 30% at some point. So that really shows the difference that we're seeing. In the next slide. So just to talk a little bit about outbreaks. 27% of the people testing positive are associated with an outbreaks. And outbreaks can occur in community settings, educational settings, congregate care, or workplaces. And one of the things that we often see is that we'll talk a little bit more about the healthcare settings that we've seen. The median age tends to vary. The median age for a case that's not associated with an outbreak at all is 44 years of age. The median age for a case that's associated with an outbreak in a healthcare setting is 70, and the median age for someone associated with an outbreak in a non-healthcare setting is 35. And that really represents kind of the impact that we've seen in skilled nursing facilities and some other places. But you'll see that middle one, school and childcare, based on what you've seen in the news, that's going to bop up a little bit next week. Next slide, please. So again, our positivities remained low since May. And what I wanted to look at here, wanted to just share is how low we are, not only in the test that we're doing, but in the percent of people. Many people are being tested regularly. So if you say, why are there so many tests and so few people that are being tested, as we aggregate that together, those people in congregate settings or in correctional settings or colleges that are being tested weekly would contribute to that difference. But the important part we're seeing there is both of them are remaining relatively low, even though we're continuing to open up many areas, including tourism and schools and everything. Next slide. So when there's a positive case, you hear a lot about contact tracing. What is that? And that's a very important public health action that we do in order to limit disease. And there's the broader actions that we do of saying wear a mask and socially distance. But when someone has been identified as positive, then we do contact tracing. And that's where we identify and notify the cases. And I'll say that if you're getting a call from the health department, it's going to come in from 802-863-7240. We aren't going to ask you for financial information, and it's going to be a human being, not a robot or not anything like that. It's not going to be a computer generated. So someone who's trained in this interviews cases to help them identify people they were in contact with during their infectious period. And then we locate and notify those contacts to identify their potential exposure and offer testing and identify if they need provide instructions on how to quarantine. And then we monitor contacts and have them report to identify whether they need to be tested or develop any symptoms. So Vermont has gotten some credit because I think the current number is that we reach 98% within, I believe it's a day. So we've been doing a lot. Hope I didn't overstate it, but we've been doing a great job on it. Next. So this is just, we're really working to box in COVID-19. And this isn't the first time we've ever done contact tracing. But some of the importance is we're testing widely. Tests are available all over the state. We're isolating the infected people. We're asking contacts to quarantine for 14 days. And we're finding out if any of those contacts are positive and then following up on them. So there's a lot of work going on to maintain the success that we've had in limiting spread of the disease within Vermont. And this looked at data from September 20th. There we go, I didn't lie. 98% of cases were interviewed within 24 hours, and 78% provided their close contacts. 48% of the contacts were tested within the 14 days of exposure. And we only identified 4% of the contacts that became a case, but that becomes very important in limiting further spread. This looks at, I think many of you that are affiliated with UVM are very well aware of the intensive level of testing that's going on there. And Jan, am I switching over to you now?
Yeah, that's okay.
I think that was it.
Well, I do need to mention what an extraordinary job the Department of Health is doing. And to actually do that 98%, and some weeks when they publish this data, you can go on their website and see it for yourself, is 100%. They reach 100% of people that they need to within 24 hours. That's incredible. And when we talk about to date, the way that Vermont has worked together with the medical center and the medical school and UVM and the Department of Health, that's what we're seeing here. And that's why some of the things in terms of reopening and allowing high school kids to play sports and go to school. That's because of the hard work. So I do need to give them high praise and credit for their ongoing work. This is what UVM's been doing in close consultation with the Department of Health. And since the students came back, the testing started before our students returned. That was really important. If anybody identified positive, they stayed home and didn't come to campus here when they were ill. And so you can see that the most recent testing is reported every week, and then the cumulative totals. The testing that's going on weekly required for our students is extraordinarily well done, and that's continuing now into the fall as the weather gets colder and people are spending more time indoors. Next slide, please. Let's start. We're going to shift to the flu, and next slide, please. We're giving you some places to go look on your own. So if you want additional information, all these topics things are happening really fast, but you can go on like the CDC website. The health department has incredible up-to-date data that you can see what's happening in Vermont. But we have these at the end, but also some of the references are right on the slides. So CDC does national tracking on influenza surveillance or disease tracking, and also forecasting. Next. But we know we have the flu every year, and this is from the CDC's website. And this season, we're making a real push, and the mantra is the flu vaccine is more important than ever. Next, and back to you, Chris.
So a couple things I wanted to note. We have greatly expanded the work that we're doing with flu this year in order to prevent what some people call a twindemic. But I don't think any of us want to be in that position where we're concerned that we might have flu and or COVID. One of the things that we're doing that's really interesting is we're providing vaccine, as we always do, at no cost for use in children and adults or those that are enrolled. But we've provided support for practices to do offsite clinics, and they have taken it and run with it. We have practices across the state that are going out and working collaboratively with schools, with community centers, with assisted living. So far, there's a flu dashboard that is being made to monitor what flu uptake is looking like. And we're working to get that so that it's public facing. It's currently in the currently being developed. But what we're seeing already is the uptake so far among kids is higher than we saw last year. And one of the challenges we have with flu and vaccine is we tend to have some of the lowest rates, not only in Region 1 in New England, but across the US. And where we've seen some of our lowest rates are particularly in the 13 to 17 year age range, and then in the 18 to 49. And when I say low, less than 40%. And what we're seeing there, what concerns us there too, is if you think 18 to 49, those are people that are working, they're parents, they're taking care of parents, they're involved in many areas of the community. So we really want to work to address that. I think the next slide is for practices and pharmacies that are offering it. We're trying to make sure that people can easily access it. If people are uninsured, they can get a vaccine at no cost at our local health department. And there's programs going on all over. The Blueprint for Health, if you're familiar with that, their facilitators are all working to ensure it's available across the state. So if there's areas where you can't access it, we need to know about it. I think
It's the vaccine under development for COVID-19. And I guess next slide. Before we talk about this, we think about the title of this was While We Wait for Vaccine. But I don't want to leave anyone thinking that the vaccine is going to be an instant panacea to this. I think that, we're going to talk about returning to the fundamentals, the hand hygiene and physical distancing and everyone wearing a mask as we go on in the presentation. But there's quite a lot of vaccine development going on. A lot of excitement about the science. And so we want to share with you what's going on nationally, how people are thinking about it, and also here in Vermont. So the first is the concept of herd immunity. And this was back in May in the New York Times, and using source of data from all over. And experts estimate that to have herd immunity, to have protection at a population level, you probably need to have about 60% of the population immune. And you can do that. That certainly can be through getting the infection, but also includes when we are able to protect people through vaccines. And you can see a comparison at that point in time. What was happening? What was the level of immunity as measured by antibodies in different locations? And we knew that New York City, as an example, had a horrendous experience and tons of cases, but they had less than 20% of the population had immunity. We know that in Sweden, as an example, that was a place that had less restrictions, although they did restrict gatherings, and did not have mask wearing. And their thinking was, we're going to get population immunity at a higher rate that way. When in reality, they didn't. And only 7.3% in the Stockholm region had antibodies, and on and on and on. So those tell us that, and there is some conversation about that now in our country. You know, what would it take to have herd immunity? Unfortunately, it would take an extraordinary amount of illness and probably exceeding our hospital capacity and too many people dying. Next. Vaccine approval processes. This is just a simple schematic from the Federal Food and Drug Administration about the different phases and the meticulous care that goes into developing and testing vaccines. Phase 1 with healthy volunteers, and you're just looking for, is the vaccine safe? And what are the side effects? Phase 2 with more volunteers, what are the most common side effects? And then how do people's immune systems respond to the vaccine? And then phase 3, hundreds or thousands of volunteers. And how do people who get the vaccine and people who don't compare in terms of becoming sick from the disease itself? So, and next slide, please. So some of this, the testing of vaccines, ordinarily it goes sequentially. There may be long periods in between and may take quite a long time. People are making it more efficient by making sure that the phase 1, 2, and 3 in some cases overlap, but are happening at a faster rate. That does not mean that steps are skipped, other than the process is as efficient as it can be. There's a whole different kinds of array of vaccines, and this is from an article in Nature. And just to show you the incredible explosion of scientific research about different kinds of vaccines that might protect us. Next. One example is called, and you can look at the article and read about all the different types of vaccines and the progress on them. This is called a protein-based vaccine, and you can see the M protein, the spike protein, and how they might make that into a vaccine, and then that would generate an immune response in a person. Next. This is something from the New York Times I thought was especially good, and it stays very, very current, and it's called the Coronavirus Vaccine Tracker, and it tells us how all these different vaccines are doing, what phase they're in terms of their trials. So for the phase 1, 2, 3, you can see that 11 vaccines are on large-scale efficacy tests, and 5 vaccines are approved for very early and limited use. And at the current time, we don't have any vaccines approved for full use, but clearly, if you looked at the same chart a month ago, it was a very different picture. So next slide, please. Chris.
Sure. One of the things I'll also just mention is that when a vaccine is in a phase 3 trial, typically they're looking at 30,000 participants in that phase 3 trial. And they at least, and I believe in the Johnson & Johnson one, I saw that they're looking for 60. And part of that, just so you understand, is that they're comparing that with the placebo. And then they look at the rate of disease and as well as any adverse effects or anything. So the phase 3, they're very large studies, and we some of the work that's been going on that you're reading from the FDA is they want to be able to follow up for 2 months after the vaccines have been administered, if it's a 2-dose, to make sure and follow through. So the next slide. This is a slide that the CDC has provided to us, and I just wanted to highlight that in the beginning, we know there will be potentially limited doses available. There's a chance that we may see up to 6 COVID vaccines in the US, but, and I know that doesn't seem like many for everything that we see, but even with that, we don't know what we'll see because typically it's not at all typical that a majority of vaccines would make it through all the testing and all. There's really some rigorous processes. So one of the things that many of us in public health learned during H1N1 is do not overpromise and underdeliver. And so one of the things we're very clear about is if there's going to be a limited amount, who do we offer that to? And let's plan that out carefully. And then they expect that very quickly as we move into phase 2, a large number of doses will be available to meet the demand. And then in phase 3, that's to talk about we have adequate vaccine, and we look at that strategy to identify do we need a second dose. There's many things that will address some of the questions there. But phase 1, this again, supply is constrained, and we're really focusing on vaccine administration in very limited settings. And the limited settings would be offering it possibly at mass vaccination settings or where we're identifying those that are at risk. The next slide. The next slide looks at what's being discussed for the priority groups that would initially get it when it first comes out. And there's been work done at the Johns Hopkins and at the National Academies. And what I just put up here is just to kind of understand what's being discussed, because as you'll see, pretty much under healthcare personnel, both are thinking frontline healthcare personnel and EMS. And then there's a lot of concern about essential workers and those with underlying medical conditions with 2 or more chronic illnesses and adults 65 and older. What will happen next with this is that the Advisory Committee on Immunization Practices will be meeting October 28th through the 30th. And they've got all of this, and they've had work groups working on this since last April. And they'll be making a recommendation to CDC on who should be in these groups. And then each state works to make sure and make it available. And they may, change it a little bit. There's some flexibility in the states as how they implement it. But just to let you know, that's kind of the thinking that's going on in the initial vaccine phase. So what is the health department doing to prepare for it? We're doing a number of things, but what I wanted to do, and one of the things we really recognize is we really need to work not only with our healthcare partners, but with those across many areas, because I think there's so much miscommunication out about vaccines that I'm actually personally concerned we're going to see hesitancy. One of the things in a study that was done, and they looked at the percent of people just generally willing to take a COVID vaccine, and in May it was 72%, and by September it was 51%. And I think we've seen the interplay of politics, and we've seen reporting being done with words like, Operation Warp Speed and pulling back and trial canceled. And many people, without the background and the understanding of the safety pieces that are in place, are left wondering what that means. So we do have a vaccine planning work group. There's a lot of work that needs to be done on the IT and the registry front so that we can identify who's immunized right away, because many of these vaccines are going to have a second dose due 21 to 28 days after. We're working on logistics and to provide mass vaccination, not only in urban areas, but in rural areas, and that gets a little tricky. The Health Operations Center is activated, and we're working with the State Emergency Operations Center to ensure we have resources to plan this and to deal with logistics. And the Commissioner's Office is forming an implementation committee, which would be an advisory committee as we work through all of this, because it's always better to get input in the beginning than after you launch something.
Yes, and move into the holiday season, but we want to talk about preventing COVID-19. Yeah. Just back to, again, some of the concepts here and why we're why we're all recommending what we are. And if you look at the iceberg, it's for every single death, you expect about 125 infections, of which 65% are symptomatic, and maybe about a third. And depending which study you look at, it might be a little bit, sometimes it's even higher, the proportion of asymptomatic. And that's really important in terms of people can be infected with COVID-19 and have no symptoms, but it's still they can spread it to others. And that's really one of the fundamental concepts for some of the prevention recommendations. Next, please. So here are how I think about three categories. Then I'll turn it over to Chris to talk about her thoughts on any or all of this, but by personal, community, and environmental. Let me start with environmental, is cleaning frequently touched surfaces and objects, like your phone, like the doorknobs. And in terms of transmission, this is probably not anywhere near a major source of transmission, but still good and basic practice. The personal, if you are sick, stay home. And that's really important and we're coming up with the flu season. There's a lot of respiratory viruses. We might be more likely to be indoors with other people. So please stay home if you're sick. Wash your hands often and wear a cloth face covering. We'll talk more about cloth face coverings, but the concept is when I wear a cloth face mask, I protect you, and the one you're wearing protects me. So if we all wear them, we're protecting each other and our families and our communities. And then the community creating physical space between people, staying at least 6 feet, or that's a brown towel apart, and whenever we can. And sometimes the mass gatherings, postponing large gatherings, and we temporarily close schools and when the pandemic began. Chris, did you want to add any more of your own personal favorites?
No, I think the one thing I would add is that one of the things we've seen that is in the US that I keep hearing comments from people that are from other countries where somebody has been moved to Mexico and they said, wow, we're not seeing the resistance. Someone was up in Canada and they said, wow, people are accepting of it. And what we've seen is that with flu in the Southern Hemisphere, when we have these people follow these community prevention efforts and saw an increased rate of flu vaccination, we see very little flu circulating. And I asked a specialist, why were they still worried about the US, or we heard it. And the comment is that because we're so resistant to following these. So not only will following these prevent COVID, but it will reduce flu, and it also will reduce that likelihood of possibly having both.
That's a good point.
So this is sort of the how to wear the cloth face covering. This from the World Health Organization, and people can just look at that. But again, it's the basics: wash your hands and be careful when you put it on, and take it off, and then making sure that you're cleaning those regularly. Next slide. This is my personal favorite, and one of the studies, it's the hair salon study. And this was published by the CDC, and it was a study from Springfield, Missouri in May 2020. And they published this in their Morbidity Mortality Weekly Report. And there were 2 hairstylists who were infected with COVID-19, and they spent at least 15 minutes with 139 different clients, and that would be a close contact definition. Every single person wore face coverings, and no clients became infected. So that was just one more piece of evidence to show that if we're all wearing face coverings, even when we're not infected, but even if someone is carrying that can also help protect us all. This is actually from the Texas Medical Association. Why did I pick this one? I thought it was a good way to think about sort of different levels of risk. And so you can look at lower risk things outside. You're going camping. Moderately low, grocery shopping. Moderate risk, shopping at the mall. moderate to high, eating inside the restaurant, and then higher risk and eating at a buffet, going to a bar, going to a movie theater. And so there are different levels of risk in the activities, particularly when we shift from outside to inside. Chris, did you want to add any of your favorites?
I guess I won't be going to a bar real soon.
Well, Dr. Carney, I want to touch on this for a second too, because do you anticipate, and I would imagine this would be the case, that the risks will continue to evolve and the varying moderations of the risk as we do go inside? Because eating outside at a restaurant seems a reasonable thing to be doing at the moment, but we're going to get pretty cold and that's not going to be happening. So is this the kind of thing that participants and viewers should be going back to because it'll be updated as the season continues?
Yes, I mean, this is sort of a general category to think about it. And yes, as the weather gets colder, we're spending more time inside. And then the health department's been watching very carefully as they've been reopening everything in the state and looking at how much disease is in the community. All those things impact that. We're telling the UVM students, particularly the ones from out of state who aren't used to it, enjoy the Vermont outdoors. I mean, there's lots of reasons that's a good thing right now.
Yeah, absolutely. Thank you for touching on that. And this is a great lead in to this topic because this is one that it seems that everywhere I go, which isn't very many places, I'll say that, but there's a lot of conversation as to what can we do, what should we be doing? And so I'm really interested, Dr. Carney and Christine, as to what are some of the things that our viewers can be thinking about as they're assessing what to do for the holidays.
Well, I'll just start, then turn it over to Chris. But this is from the CDC's website again, and this just shows you some of the things that you consider in terms of the risk of virus spread around the holidays, and just the holidays starting from Halloween all the way through New Year's, perhaps just lots of different holidays. But first is the community levels of COVID-19. How much of people inside or outside? We just talked about that. Longer times gathering, say inside, would be riskier or higher risk of transmission than shorter visits. The more people that are inside an indoor space, the higher the risk. And that gets back to that physical distancing and what we know about droplet spread. Where are people traveling from? And Vermont has a whole set of requirements for people traveling from different states. And then how are people behaving, not in terms of social behavior, in terms of, are they wearing masks? Are they staying away if they're ill, have any symptoms, those things. I'll turn it, Chris,
Well,
you must have a perspective on this one.
Halloween is coming up, and that's a big holiday for many of us. And more and more, what it is many people have heard this for months. Is take what you're hearing and apply it, because I think many of you can think about it. So if you're going to do trick or treating with the kids, or if you're going to do something, it's going to be maintaining a safe distance. It's going to be wearing masks. Sometimes you can have fun with a mask that you tie in. I mean, in Halloween, you typically wear masks, but it's using what you know and thinking about it. And I'm even seeing that, with some thought, I've even seen where there's a smaller yoga class that could gather with 6-foot distances and masks on, and windows are open. But we know that we want air moving through. We want to protect the spread with the masks, and we want the distancing. And with that, you've really decreased the risk.
And so, and I know people should be looking to, because the CDC has guidance on Halloween. And so is that really what your recommendation is to see what the guidance is and then assess your own situation to try to make the best decision?
Yeah, I don't think Halloween should be canceled at all. And Dr. Levine has been promoting that for about a week. He's pretty excited about it, I think.
That's good. Thank you for sharing that. I know you have more to share with us here too.
Well, these are just some of the things that we've already said before. If you're ill, We just ask people to consider others. Um, and sometimes there's a misperception that because someone's a close friend or a family member, they can't be contagious with anything. And I think that we have to kind of think about that and say, all right, how can we be cautious, even when we're considering gathering with our family members and close friends, because the same principles really apply.
I just want to tell my crew here, my computer just froze up on me, so I'm going to need help moving the slides forward. But I wanted to stop for a moment, Dr. Carney. One of the things that you have mentioned to me is, well, what about if I take a test, a COVID test right before Thanksgiving? Is that okay that I can then go and see family? And if there is somebody in my family that is of high risk, is it safe that I am taking a test the week before? And I bet a lot of people are thinking about how do they come up with a strategy to do that to fit in to some of these celebrations.
Well, I'll give you my how I'm thinking about it first. The first is the test is the moment you take the test, all right? And the next 24 hours, if you go into a crowded place with no mask on, all bets are off, right? And so I think that it's all those factors that we talked about. Is somebody taking a test and coming from a very high prevalence area, and then they're staying overnight at two different places on their way to get here, and then they have the sniffles when they get here. It's complicated, you know. If but I think what we're encouraging people, particularly since in the Northeast, we are seeing increasing disease in the Northeast. And some of the concerns are that we are going to see more and more disease pop up in the smaller family and friend gathering, particularly as we move inside, particularly around the holidays. So we have to rethink that. If your usual holiday gathering on Thanksgiving is to have 35 people in an 8 by 10 room, well, pause. Think about that. Can you spread those gatherings out over several days? Can you have fewer people? Can you space out the chairs? Can you remind people to, are people wearing masks? Can you remind people to please stay home and don't be offended to have those conversations?
So when you raise a really good point too about spreading things out, and I think not just the chairs, but maybe the celebrations. And so I think that's something that I would love to hear maybe Christine's perspective on it too, and just some more thoughts as to, if you have family that maybe is outside of the state, and maybe it's a state, maybe it's New Hampshire or Maine, and depending on where they are in the counties, looking at that county's information, because I know that they fluctuate quite a bit. And so maybe a strategy could be looking at the counties as to where your family could be coming from. And then maybe also having backup dates and or having kind of extension of holidays. Maybe there's one group that gathers a small gathering one weekend. I feel like November could be one giant Thanksgiving. And so there could be some celebrations, with portions of the family if everybody feels good about it in the counties and everyone feels healthy. And then maybe do another section of the family. Is 2 weeks a reasonable time to think of trying to spread that stuff out, or does that not make much of a difference?
I think the more you spread out, the better. And one of the things I'll say is the reality is that people do need to see each other. I mean, I have a 92-year-old father that lives in central New York, and the family there all work in the healthcare industry. And I find that you have to take what you have to look at the stuff and make your decision. For me, I know that if I need to go, I need to quarantine after I have all the specifics down. Because what I found too is everyone has different interpretations of this. And so if you follow the CDC guidance or the health department guidance, you're basically basing it on a lot of research that's been done and what we know to date. And so by keeping yourself safe, you can do that. But I do think that people will try and space some things out and it will work. But the reality too is that there are family members that we need to see and there are things that we need to do. And so if you do that, then when you come back, be sure and just quarantine, and you can get a test if you want to partway through there. But recognizing that there's clear guidance so you're not left out just figuring out what to do. I will say the health department website has some very specific guidance that it's made as simple as can be with pictures and all, that as I looked through it earlier today, I thought, this is what we need. Nobody wants to read 18 pages to figure out if they need a test.
Visuals always do help. Thank you for sharing that too. And it's interesting just to be seeing the increase of what's happening in some of the schools in Chittenden County. And I think that, it'll be very interesting to see spreading out some of those celebrations in November and then coming back to school or quarantining. If is it realistic? And is this what I'm hearing too from you, that if a family goes to an out-of-state area that might be in a red zone and then they come back, should the children not go to school for 2 weeks because they're quarantining?
Ooh. I don't want to answer that without doing a double check of the school guidance and all, but I do think it has to be considered, and you look at what you've exposed them to. And I know we're changing some of the school stuff day to day, but I think the first thing is limiting the exposure if you can. But for many adults, it's also very tricky, and you have to make a decision sometimes of, I better not go on that trip. I know that that's happened a lot, and that's why we're seeing the cancellations. But I think also to recognize that when you do need to go, you have to look at how that will impact the return. You just can't go back to life as usual when you first come back if you know that you've gone to a red zone and had some exposures.
Yeah, absolutely. So what I'm hearing too is one of my takeaways, and hopefully our viewers as well, is just the planning and the thoughtfulness that you need to put into this, and then knowing that it could all get thrown out the window because somebody doesn't feel well. And so that's really what I think that seems to be 2020, right? Some planning and then adjust. And so maintaining that flexibility, I think, is one of the things that will be very important for us to consider. We do have a few questions, and I want to get to those in just a moment, but let's keep going because I know you still have more information. So let's jump over to the next. Is there anything else on this slide that you wanted to cover, Dr. Carney or Christine?
No.
Okay, great. So let's jump to the next slide. And then I'm not sure who's going to take, I know we've been talking about a lot of this, but what else might we want to discuss here?
I'm personally looking forward to Halloween. I've been thinking about how I can put out in socially distanced parcels, individually bagged candy for children and where I live, and in a way that is safe for them and safe for us. And I think the key is what Chris said. We just have to think about it and figure it out because we all enjoy different holidays.
Absolutely. Great. Thank you. So I think we can move to probably the next slide here too. I do want to pause. We'll get to the questions in just a moment, but one of the reasons why we're also here and that we continue to do these webinar sessions led by Dr. Carney is the fact that you lead our Master Public Health program at the College of Medicine. And before Dr. Levine, and I believe there was a predecessor before that, but you were the commissioner of the health department here in the state of Vermont. So I just want to thank you, Dan, for always being willing to share your knowledge and your insight and the data, because I know you have plenty of things on your plate, but we as a community really appreciate you taking the time to go through this information. And one of the reasons why it's so important that you do share this information is you are on the cusp of it. You are in the middle of it every single day. So as our leader of our public health program at the College of Medicine, and so for folks maybe hadn't thought about what is a Master of Public Health. And I know Chris Finley has that also in her credentials. And so Dr. Carney, this isn't really trying to dive into the program, but just give us a quick overview. What does the Master of Public Health program look like here at UVM? Can you turn back on? Hang on one second. Yeah. There we go. Start back over. Your microphone was muted for a second. Go for it.
Oh, I just said that it very simply, public health deals with populations, looking at prevention and in populations. So that perspective is something that you get in an MPH program. Chris and I have both been through an MPH program, and what does that tell you? It gives you a sense of a larger perspective. So you learn some of the math, the biostatistics, and epidemiology. The epidemiology is kind of the language, and you hear about the disease detectives and what we talked about, the proven public health science of contact tracing that Chris talked about, and how they do that day in and day out now at the Department of Health. It talks about social and behavioral sciences, which are, how do we shape individual behavior, both people themselves or the social norms in the community around things like tobacco use or drug use. Our environment's very important to health, and our policies. Those are the most controversial, but the policies of sometimes what the legislature does also can help us. So those are sort of the broad categories that you learn. In our program here, we have all the national competencies that you would learn in any public health program. It's a graduate program. Ours is 100% online here to make it more accessible to people. But these are the quantitative sciences I mentioned. We have global and environmental public health. There are a lot of connections between those two areas, and health policy leadership and advocacy.
Great. Thank you so much, Jan, for sharing that information, because I think one of maybe the positives of being in a pandemic and living through it is I feel like we're all crash course in public health and really understanding epidemiology. I think that is a term that many of us didn't know or didn't know what epidemiologists did. And so I think it's a really fascinating time for people to realize that there's an educational component that people could pursue if they are finding public health fascinating. And in this slide, I just think it's really interesting to see the breadth and the diversity with a public health master's and a career in public health. And Chris, maybe I'd love your input on this because you work in the Department of Health, and what an exciting field it is, even when we're not in a pandemic. But maybe just your perspective on the wide variety of opportunities there are in the public health field.
Sure. I'm also a nurse practitioner, and I went into public health after being discouraged at the individual level because you were seeing so many illnesses that really needed to be prevented or better managed on the population level. And I'll go with prevention. And although that I shouldn't say discouraged, because the joy of being able to see people one-on-one is something you don't have in public health. But what you have is this variety, I would say, in every day. And right now, I've been an immunization program manager for the longest time. I've stayed in a position because I like changes. But what I find is it brings me everything. We're using the data to try and look at vaccination rates and to assess looking at effectiveness studies. And then we look at vaccine preventable disease prevalence. But also there's major policy issues that are impacted with vaccines, looking at the school requirements. There's communication challenges. How do we address the vaccine hesitancy and the concerns that are out there? And then there's all the quality work that we might do. So for me, the program I'm in just brings so many different pieces together and allows me to merge them all into one topic. But then for people that like to really stay focused on something, there's a lot of areas. We've got data you could analyze for years. So there's lots of specialty areas. And I really feel like public health is finally gaining some of the attention that we hadn't had over years. As we look at climate change and as we look at what's happening with the pandemic, people are understanding, oh, it's not just that you're trying to prevent us from getting chronic diseases. It's a bit more than that.
Absolutely. It is incredibly broad. Thank you for that perspective. I just think it's a great opportunity to share with our viewers a little bit behind the curtain of the field of public health. I do want to ask a follow-up question to a little bit of what you just said too, Chris, in terms of the hesitancy to the vaccine and the concern that people are having. And Dr. Carney, you and I've talked about this a little bit, the politicization of the vaccine. And Chris, you described that the Department of Health is talking about, robust communications plans when indeed we have a vaccine. And Dr. Carney, I know in a presentation that you did for our continuing and distance education team was really talking about how to try to take it out of politics for the good of the community and all of us. Thoughts on how we can do that as community members and citizens to see it seems like there's a different perspective on it and a different tweet and something different every single day, that it's hard not to be confused, and it's really challenging to not be hesitant. So I know these are things that you're talking about, Chris, at the Department of Health. What can we do as community members to help and to get the best understanding of what we should do once a vaccine is out?
I think that's a great question. I think that we had the emergence of SARS-CoV-2, and then we've learned all the social distancing and things that we can do, and we're beginning to understand treatments. But what Jan showed earlier is that we don't want to wait and get herd immunity by being exposed and getting the disease. We absolutely need to prevent it. And so if we want to move beyond this limited life that we've got, some of the restrictions that we have, we're going to need higher rates of vaccination. We're going to, I'd like to say 70%, but sometimes we think a little bit lower. But if we only have 20 or 30% that take it up, we're going to be in this chronic place where I think many people want to move beyond that. The second thing I'll say is that when I take off the world that I know and just read the paper and listen to the news, I think I understand why people are concerned. It sounds like it's just being rammed through, but nothing is being skipped in the phases. What's happening is that typically you have a phase 3 and you determine if it's effective, and then you prepare the vaccine and manufacture it. But we're doing those simultaneously, which is saving a lot of time. And the recognition is some vaccine will be thrown out and wasted. But some of the phases that have been done may have been overlapped a little bit because of the funding that's been put into them, but nothing is being skipped. And in fact, they're looking at different programs at the CDC where they might do more expansive safety testing, because no one wants to be part of promoting or taking a vaccine that hasn't been proven safe.
Thank you, Chris. And Dr. Carney, you made a point in a recent presentation noting that several of the very largest pharmaceutical companies joined forces, if you will, in a pact to say, we're not going to skip these steps. This is not going to, we're not cutting any corners. Can you just talk about your perspective as to how important even that statement is from some of the large pharmaceutical companies?
I think it's huge. I think everyone wants to use the science, use the evidence to make sure that any vaccine is out there for the public is safe and effective. And you have the data to demonstrate that. And it's about looking at the data and making that available. I mentioned early on, when the health department puts up current data all the time, you can see exactly what's going on in Vermont. It gives you confidence. And that's using the proven public health science. And I think the FDA's information, we look on their website as we look at that, and it's pretty detailed. But when people see that and then they sift through that, they can see that these are the scientific steps that make sure that we have something that is indeed safe and effective for the public and that people have confidence in.
And one of the things, this is probably our fourth or fifth coronavirus topic webinar that Dr. Carney and I have done together over the past 8 months. And this list of resources hasn't changed. And so this is the list of resources that Dr. Carney looks at, and I bet Christine looks at too. And so this is really, try to take yourself out of the social media and maybe out of the day-to-day news that you might be monitoring, and head over and look at what the Department of Health, with the CDC, with the World Health Organization, and also I always appreciate the articles that you have shared with us today. And we will share all of these links out with everybody with the recording of the webinar. I do want to follow up with just 2 quick questions. I know we're running out of time, but I want to get back to these questions. Kathy asks, and this is a little bit of a follow-up to what we were talking about with, visiting holidays, and then how do you come back, and do you go back to school? And so Kathy was asking, how do we protect children in childcare who may visit family settings over the holidays? Should they self-quarantine following travel and not return to care? I don't know if either one of you have a thought on that.
I know there's very specific guidance on that, and so I would say follow the guidance and talk with your childcare provider.
Great, thank you. And then we also have a question, how can we utilize data-based strategies and scientific persuasion to promote preventative behavior? That's a wonderful question. Dr. Carney?
That's a tough one. I think we keep doing what we're doing right now. I mean, public health has never been more important and more visible. And so that if we look at the kinds of evidence-based strategies and how they work, I think that helps.
I think we need more research on vaccine communication. We were part of, so I was part of some research before, because sometimes we think if we just hit them with the facts, they're going to take it. And there's research showing maybe not so, but I think with the work that's being done now, we're going to have to really, from the beginning of implementing this COVID education and promotion for the vaccine, it needs to be monitored, it needs to be tracked, and we're going to have a body of research that we can learn from, because there isn't just one characteristic or one type of group that is hesitant to vaccines. It used to be they wanted to say, oh, it's upper income white people. It is across the board, and we're seeing hesitancy in the very groups that we're seeing higher risks, higher rates of COVID. So we'll be using the research and the knowledge we've built over years regarding vaccines, but this is new, and research is incredibly important as we work through this to understand what works.
Great, thank you. That's an excellent point. And I want to just kind of circle back to the point that you made earlier, Christine, about the opportunities to find flu vaccine. And so and remind me again, is it on the Department of Health website where people can go and look for where the vaccines are available?
It's Flu Finder, it's there, but I think if you also Google Flu Finder, you'll be able to have it. But it is available at pharmacies. It is available at primary care providers if you've got a primary care provider. And if they're having a clinic, they'll let you know. But I think oftentimes start with, for adults, a pharmacy or your primary care provider is a great place to start, so we can make it easier for them. And for children, to very often available at pediatricians, and more and more pediatricians are actually offering vaccines for the parents so that they can get them all at once without having to do 2 stops. And then there's some school and outside vaccine opportunities.
Great, thank you. I know we do have one more question. And this may be, Dr. Carney, thinking back to some of the information that we had seen earlier in your presentation. What are the current insights into the mutative characterization of the SARS-CoV-2?
I'm sorry, Nicole, was the question, is the virus mutating?
Are there insights into the mutative characterization? Yes.
I think people are looking at that. That's one of the things that they're looking at, in addition to sort of how long does the immunity last. So I don't have a crisp answer to that, other than the research is ongoing. I think that's very important to know as we go forward.
And where would you look to monitor that kind of research that's being published on it?
I first look on CDC's website and the World Health Organization and look at what we're seeing in terms of global patterns. I would start there. Also, the National Institutes of Health has an incredible amount of research on their website, and current research both on vaccines and the virus itself. I would start there. There have been thousands and thousands of scientific papers published on the topic, all aspects, since the pandemic began. But I would start on those 3 websites.
Great, thank you.
And I might add in the New England Journal that has the free COVID and JAMA, because I'm thinking I saw an article that referenced this, and I can't come up with I don't want to come up with a summary without thinking back to it. But I do think that making all the COVID articles widely available and free on JAMA and New England Journal is particularly helpful.
Great. And Christine, my final question, when the vaccine is available and going to be available in the state of Vermont, how will we know? What will be the best way for people to know?
I think you'll know. So probably when the vaccine is available, that will be national news. What they will then do is allocate it to each state. And so you can expect when you hear it's available that it will be allocated to the state. My hope is that we'll be very transparent, and I think that's our goal. We'll be identifying those highest risk groups that we want to reach out to, which includes healthcare workers and EMS workers, and there will be contact there. But I would hope that between the media briefings that are there twice a week and what we do, that we can communicate and allow people to understand not only is vaccine here, but when will it be available for the general population. And I'll just say that right now what we're doing is enrolling providers. Every provider has to be enrolled that's going to receive COVID vaccine, and we're in the process of getting ready to launch that to make sure our providers are ready to receive the vaccine.
That's great news. Thank you both. Thank you, Dr. Carney. Thank you, Christine, for your insight today, for your comforting words, just to keep going on what we're doing, keep wearing masks, maintain that social distance, and really those resources that we all should be looking towards, and some of the questions to consider as we are getting closer to holiday gatherings. Thank you both. Thank you everyone who watched this afternoon. We will share this recording, and we wish you a wonderful afternoon. Take care.
Thank you very much.
Thank you.